Ed, let's talk a little bit about the Holland Foundation. I'm just kind of finding out a little bit about this and learning about the work that you're doing. It's really, really exciting and such a huge need. I'd like to kind of hear just from you, sort of, how did this sort of become? How did this idea come to you?
Early in my career, I did a cornea fellowship and then did a fellowship in immunology, thinking that corneal transplant rejection was the biggest unmet need on why we had, long-standing blind cornea patients. And what we realized is that it's not just immunologic rejection, it's patients who lack the ocular surface epithelium, some conjunctival injuries like Stevens-Johnson syndrome or chemical burns, to limbal stem cell injuries, and they all kind of evolve into that, from contact lenses or mitomycin, things like that. So there are hundreds of thousands of patients that can't grow their own corneal epithelium, and I kind of backed into taking care of these patients because I inherited a bunch of them, and so we had to kind of figure out how to do that. And so to do that, we do what's called an ocular surface stem cell transplant, where we provide new conjunctiva or we provide limbal stem cells, and we combine those procedures. And we get donor tissue from either a deceased donor or a relative, and we replace the ocular surface. The problem is the rejection rate is very high in these patients, and you have to use systemic immunosuppression, just like an organ transplant patient. And unfortunately, ophthalmologists, cornea specialists are not trained to use those medications, and that's the huge barrier. So we don't even unfortunately take care of even 1% of the patients with this blindness.
Yeah, so it's kind of it needs to be a team approach. That's sort of the key to this, to really what your foundation is doing is showing how this can work, how you can bring in doctors who do have those skills and using those drugs for immunosuppression, combining that with the surgical techniques that you're developing, and that allows you to have a more successful result.
The concept of team is exactly what this is. So we created in Cincinnati, we called it the Cincinnati Protocol, a team. So first of all, you need the cornea specialist as the captain of the team. You need glaucoma specialists that are trained to take care of these severe diseases with bad conjunctiva and sclera. They have to learn how to handle those glaucoma surgeries and that. We need oculoplastic surgeons because lots of times the lids are scarred from the chemical and thermal injuries. And we need retina specialists. So we have a team of ophthalmologists, but then we need an expert in immunosuppression. And that, who invented immunosuppression was the nephrology team. So the nephrologists were the first to really make that successful, the kidney transplant team. So we have a nephrologist on our team. And then the day-to-day management of these patients gets to be burdensome, and a cornea person or a staff person in the average ophthalmology clinic can't do it. And what does the renal team do? They have a transplant coordinator, a nurse that oversees all these patients. So the other member of the team that's critical is a transplant coordinator. And we realized when we built this team, we have good success rates. Overall, our success rate is on average about 75%. In some cases, some diagnoses over 90%. But we are one center, and patients can't get to us. We do a lot of these procedures, but we can't begin to take care of all these patients. So the goal and the reason why we started the Holland Foundation was to create centers of excellence to build the teams that you're referring to across the country. We've opened our first center of excellence outside Cincinnati in Southern California at University of California, Irvine. Marjan Farid is the cornea specialist. She's the quarterback. We've just hired our transplant coordinator. But our goal is to put 7 to 10 centers across the United States, and also look internationally to build the same type of team approach.
Well, I know this is a real passion for you, and what is it that ophthalmologists can do? What can we do to help that foundation?
Well, so the barrier to get a cornea surgeon involved is really twofold. One is understanding immunosuppression can be used safely in these patients, and the patients are not going to die. They can take this, and the toxicity is very, very minimal. So we have to find a nephrologist and do that education and connect them. But the other one is the transplant coordinator and paying that salary. And unfortunately, if you look into ophthalmology, there's no way to bill for that transplant coordinator's time. We don't have those codes where in organ transplant they do. So one of the first things we do is raise money to hire a transplant coordinator to get the center up and going. Ultimately, we want that center to be self-sufficient, but raising money is going to hiring our transplant coordinator and doing the education.